Our next speaker, Dr. Katmakov, will be sharing his experience with femtolaser-assisted deep anterior lamellar keratoplasty.
Hello, highly esteemed colleagues and conference listeners. For me, it's a great honor to speak here at the conference of All India Ophthalmological Society. Let's just imagine you and 9 other eye surgeons enter the operating room, and you see that you need to perform deep anterior lamellar keratoplasty. It means that you need to get as close as possible to the descending membrane and the endothelium without damaging the membrane integrity. Right now, 10 eye surgeons are performing deep anterior lamellar keratoplasty in the different parts of the world. But unfortunately, I will have to disappoint you, and within the next hour, from 1 up to 5 eye surgeons will not be able to complete it and have to switch to penetrating keratoplasty. And who knows, one day you may also be among these 5 surgeons, right? Let me show you something. Here are my first 2 slides.
En sista gång. Please! Bara en gång till. Setting fire to our insides for fun. Collecting names and never missing them.
So, can we apply just a little magic and make DLK success rate higher? We know that DLK has a dark hallway of unpredictability and foreseen events, but we can either accept this situation as it is, or we can find ways to change and improve it. And we know that deep anterior lamellar keratoplasty has become an elegant solution for many corneal diseases, exactly keratitis, cornea opacities, of course, cornea dystrophies. And the surgeon's key goal is to leave as little residual stroma over the own recipient's descending membrane. And of course, the big bubble technique developed by Dr. Anwar and Dr. Teichmann has become the base surgical procedure. We know that the required data have already been found, and the direct interconnection has been proved. Which can be described as the thinner the better. It means that the less stroma will leave over the descending membrane, or what's ever better, if the descending membrane is completely exposed, the smoother donor-recipient interface and the high visual acuity and visual quality can be. What to do if perforation occurs? We know that all perforations can be large, small, located in the center, or located on the periphery. In 2018, at the Cornea Day in Moscow, professor from Italy, Vincenzo Cernicolo, presented an outstanding report. In this report, author presented various technical solutions and provided data of the frequency of cornea perforation, which ranges from 4% to 39%, and the frequency of forced transition from DLK to penetrating keratoplasty from 0% to 60%. Option number 1. What we should do if we see peripheral macroperforation. Initially, it can be a helpful step if we not injecting air. In the same report, Professor Cernicolo presented his own algorithm, which includes 2 steps. First step, suturing the donor stroma, and only then inject the air into the anterior chamber. Option number 2, peripheral microperforation. In this situation, we don't see the gross deformation of the distemic membrane, and that's why this situation allows us to continue the surgery. But we still should be ready to perform the second stage of the surgery in 1 or 2 days. In the situation when we see a double anterior chamber, namely we drain the fluid and inject a gas-air mixture into the anterior chamber. Option number 3, central macroperforation. Central macroperforation can be a real challenge, and each of us knows the frustrating feeling of having to switch to penetrating keratoplasty, and in this time we may feel confused. You may get even more confused if you have persisted and continue the DLK and try to bring the edges of the distemic membrane closer together. And at the end of the surgery, you will see the bad distemic membrane, and you have to make another tough decision to use the second donor material and redo the whole process within penetrating keratoplasty. But sometimes we can be successful. The fourth option, we can describe the situation when we see central microperforation. This case can be useful initial injection of air. This is my clinical case. It's a patient with keratoectasia, namely keratoconus stage 4 and central corneal thickness 388. First step was the femtosecond laser dissection of the stroma. Then a tunnel was formed manually for further injection of air, and the first attempt ended up to be unsuccessful. The second one worked out. But at the moment of stroma separation, we noticed a flow of fluid from the anterior chamber, and in this situation, injection of air led us to visualize the defects and led us to complete the process of preparing bed for donor stroma. We know that there are situations when with complete transparency of donor-recipient complex, it's not possible to achieve high visual acuity, and any central defect doesn't make the situation optimistic. After 3 months, visual acuity was 20/50 Snellen, and applying higher degree of the image, we don't see the formation of scar. The optical zone is transparent. What if we close your eyes, open them, and imagine that there is no perforation? What techniques can help us avoid perforation? First one, DLK removal of stroma from the periphery spirally. The second one, double bubble DLK. The third one, DLK using blunt tip scissors. Another useful technique, the technique groove and peel. Summing up the set above, the following tricks can be used in practice. In case of peripheral macroperforation, initially not injecting air. In case of peripheral microperforation, we can continue the surgery but still should be ready to perform a second stage of the surgery. In case of central macroperforation, we can make an attempt to bring the edges of the systemic membrane together or be ready to switch to penetrating keratoplasty. And in case of central microperforation, initial injection of air. Some useful techniques you can see on the slide. And is it difficult to perform keratoplasty? Definitely yes, but it's not impossible. At the beginning, we said that from 1 up to 5 eye surgeons have a potential to not to complete DLK. And we can change, we are able to change this number, and at least 1 or 2 more surgeons will achieve the success. It will already be a big victory. Thank you all.
Thank you very much for your interesting talk, and we have